Dr. David Rolfe, can you kindly introduce yourself?
Well, good evening. My name is Professor David Rolfe. I'm a Professor of Urology at University College London. And my main area of interest is andrology, in particular erectile dysfunction management with penile prosthesis and Peyronie's disease. We also specialize in phallic reconstruction, patients that have lost their penis for a variety of causes, and we fashion a new penis from them, either from the arm, the leg, or the abdomen. We have a special interest also in the management of priapism, and I run quite an extensive fellowship program at the university for fellows from all over the world. We've had fellows from every continent, as well as teaching our own doctors in the UK, and that gives great satisfaction to see them aspire to becoming great andrologists in the future.
What's your opinion about Dar al-Dhukura centers?
Well, coming from the UK, I've heard of these centres, but then I'm travelling in the Middle East a lot because it is a Middle Eastern venture. What I've heard is all good, mainly because it's protocol driven. The patients get exactly what they're told they're going to get, and it's honest medicine. They obviously is a private institution, but they're not over-treated. They have the state-of-the-art treatment from good and well-qualified doctors.
What is your opinion about Dr. d.اسامة غطاس as our medical head of Dar al-Dhukura centers?
Well, this is my first visit to Cairo and to this centre. We've done 6 cases today. We've also seen some patients in the clinic. It is clear that the patients, as soon as they come in here, love him and respect him. And again, to have that doctor-patient relationship like that is absolutely excellent.
What's your opinion about Dar al-Dhukura surgical team?
As I said, we also went to the hospital, the theatre staff. They are doing a lot of penile prostheses and they know everything about penile prostheses. So it makes visiting surgeons, it makes my job much easier when everyone around knows exactly what I'm going to ask for. So they're very friendly, professional, and they couldn't help you more and make you feel relaxed.
Kindly give us your opinion about working together in surgeries with Dr. d.اسامة. How well the surgeries went?
I think the surgery, I travel all over the world and do these surgeries and at home. I think if you keep on doing the same operation and stay within your capabilities, then you're going to get good results. And the same quality of treatment is being given here. I like to say in my own institution, probably actually better because of the staff that they have.
Considering the hospital and the theatre, is it of a good quality as in UK outside Egypt?
We have fewer staff. So I don't think the patients need to be worried about the quality of care they're going to get. I mean, it's a private institution, so you expect it to be, quite a nice hospital. But the quality and the attention to detail, and everyone is abiding by usual theatre rules. So I think the quality is exactly the same as in the UK. The environment and the number of staff that they have is much more, and so that makes working much easier.
There is a controversial debate about cavernosal tissue sparing during malleable prosthesis. We would like to know your point of view.
I think cavernosal sparing in penile prosthesis surgery in general has been a topic really for the last 3-4 years. We now try to only dilate up, possibly with the furlough or a very small dilator. You don't need to do sequential dilatations, so you're theoretically going to preserve that cavernosal tissue around the penile implant. So I think with the inflatable implants, I think that's good, and it's I do that. I just dilate with a 10 dilator, and that's it. I think with the malleable prostheses, you still have the cavernosal sparing dilatation, but of course, when you put the prosthesis in, then depending on the diameter of the prosthesis, then that's going to occupy that space come what may. So For example, if you're going to put a 13 millimeter implant in, then that's the same as dilating up to 13 millimeters with a dilator. So then you probably wouldn't spare the cavernosal tissues, because the implant itself is designed to fit quite snugly in the corporal bodies. And surgeons being surgeons, they try and put the biggest implant in possible to get better patient satisfaction. So I think with inflatables, possibly yes, because remember, with inflatables, the majority of the time it's deflated. But when it's inflated or a malleable penile implant, then you're not sparing tissue with that. Putting a small implant in, I mean, the general feeling is that you put a penile implant in that is the correct size for the penis, and that's the length and the girth.
What's your opinion about implanting a smaller size penile implant inside the cavernosal body?
The theory of putting a smaller implant in, I mean, that went back many years ago, probably 20 years ago, where it was called a tutor. So you have this small little implant basically acting as a scaffold to help with a bit of rigidity. In essence, it was just like a penile implant. And so, I mean, that died a death. So I think this will die a death as well. So just put in the right prosthesis size, because otherwise you're going to have unhappy patients.
Dr. David Rolfe, can you kindly introduce yourself?
The Gattis technique, I think, is a really nice technique. I've not used it myself, mainly because we don't have, by and large, those sorts of patients in the UK. But there are patients that have, very large penises where, the size that you have is just not good enough. I've used mesh in other circumstances in the penis, and it works beautifully. I haven't actually used this technique myself, mainly because I haven't had a patient to use it on. But I mean, the principles are good. The paper was well written with good evidence. And if you want more than 13 millimeters, then just wrap some hernia mesh around, and it seems to go in quite nicely without complications. I haven't had complications when I've used hernia mesh for reconstruction either. So there is no reason to believe that it's not going to be a good operation.
From your point, how well penile implant surgeries are done in Egypt and Middle East?
There's a lot of penile implants that are done in the Middle East or in all of the countries. By and large, I think they are done nicely. The surgeons are always willing to learn new techniques, which is really good. You don't stay with your technique, you're always willing to improve it. And what I've actually seen on my travels is that actually they're very good surgeons, and they offer appropriate treatment for each individual patient.
What is the future innovation that is developing in penile implant surgeries that you think will make a huge difference in a couple of years?
Well, the future of penile implants, and I think in the next couple of years, not much. I mean, there are some changes to the implants that we already have. I mean, the companies need to be commended because they're always trying to improve their products, which benefits, of course, the patient. So in the next few years, there'll be some slight modifications of pumps and cylinders and the rigidity. There's a new company on board as well, so competition is good. There's some new instruments, new dilators. But I guess what we're really looking for is the electronic version, where we get away from using a pump in the scrotum. I think the patients will quite like that. That's not going to be around for 2 years. In the next couple of years, it'll be, my view is probably it'll be 5 to 10 years before that comes on song.
What is your opinion about Zakura medical protocols?
Yes, I've read the protocol, and I think it's excellent. I mean, it's got every organization's guidelines there, so the American, the European, and it's quite comprehensive. It goes through quite a lot of the common conditions: erectile dysfunction, premature ejaculation, Peyronie's disease, aspects of infertility, male infertility, for example. Protocols, by and large, are good, particularly if they're being used in more than one center, because then the patient will get the same quality of treatment. And you don't want patients having one form of treatment in one centre and another form of treatment in another centre, paying the same amount for each. So I think it's good for the patients. I think it's good for the junior doctors as well, because you just go by the guidelines, you go by the book, and that's what protocols are for. Also, protocols are good because you can document all the data. And so if you are research orientated and then you're documenting the same protocol in different institutions, then of course you've got more patients and more data to write papers about. So by and large, I think protocol-driven medicine is good.
After your journey through الذكورة centers and meeting Dr. د.اسامة غطاس, would you like to join us as a consultant?
Yes, I have patients who are also living in Egypt that come to see me in London. Clearly, the quality of care that they're going to get here is excellent. I'm very happy to operate here and see patients here. I go to some countries and I don't feel comfortable doing big cases in their centres. We've already done some big cases already here and they've gone quite well. So I'm very happy to be a consultant here, yeah.